so some of this we have already talked about. So again, stop me if you have questions, but I'm just going to roll through it. So a hematoma is the collection of blood in the tissues after an unsuccessful venipuncture or after the venipuncture site is discontinued and blood continues to ooze into the tissues. So remember whenever I told you guys, discontinuing an IV is not difficult. You loosen up the tape, you pull out the catheter, you make sure the catheter is intact, and you cover that insertion site with a gauze. Failure to cover it until it stops bleeding or for long enough for a little small clot to form will result in a hematoma. So a lot of times when your patients are super bruised after they get an IV, it's because the nurse didn't hold enough pressure for long enough and it continued to ooze into the tissues that blood did after the IV was taken out. So just be mindful of that. So the vein can be nicked during an unsuccessful venipuncture. So sometimes you can hit the sidewall of a vein when you're starting an IV and not actually go into the vein. You know, you can pop it from the side and it can bleed and you can have some swelling and a hematoma form, but you're not actually within the vein. You can have leaky veins because of frequent use of the same vein for venipuncture. So if a patient is drawn from the AC for a blood draw and then they're drawn again from the AC, sometimes when you tie that tourniquet, that old venipuncture site can bleed a little bit. If we never want to tie a tourniquet above an infusion site, so just make sure that if you are, so I guess I should say this. If you attempted to start an IV in the hand and you were unsuccessful and they could not be stuck on the other side, when you tie your tourniquet, where would you be able to stick that patient if you previously stuck them in the hand? Where would be an acceptable site?
Anywhere above that?
Say again, I can't hear you, Kelsey.
Anywhere above that?
Anywhere above that, yes. But when we tie that tourniquet, what could possibly happen to that insertion site where they were previously stuck? We could cause a hematoma to form there because they were already stuck there, right? And when we insert pressure up here, it could cause a hematoma to form here. So if you have the extra hand, or you can stick on the other side, if it's not contraindicated, make sure that you're peeking at that. You're having somebody a little bit of pressure, or you're waiting a few minutes before you immediately tie that tourniquet again, or they could start bleeding from that other side and get a big ugly bruise there. Okay, it's not going to cause any permanent damage, but they'll say, oh, look what she did to me, it looks horrible, it looks horrible. Make sure that you held enough pressure and stopped that from leaking. So we've already kind of talked about all that stuff. So the biggest thing is preventing that. So placing your tourniquet properly, using a small needle in the elderly. We want to use a 20 gauge or higher if we're giving blood. If the smallest, okay, so if your patient's not getting blood and they're just getting some normal saline and they're only going to be in the hospital for 24-hour period, then a 22 gauge IV would be something appropriate. If they're in the hospital having a baby and we know they're going to lose blood and we know they're going to get some medications that are harsh on their baby, we're going to want to go an 18 or a 20, something higher in gauge, a larger diameter for that patient. Sometimes you can apply a blood pressure cuff in place of a tourniquet. All of those things could possibly prevent hematomas. So 1 to 2 minutes is the length of time that you are going to apply pressure when you are removing a catheter. If we elevate that extremity, we will decrease some of that blood flow. And once a hematoma has formed, you can apply ice if needed. Infiltration. I feel like we verbally talked about all this, but I guess we didn't have the PowerPoints to go over it. We want to make sure the way we're going to prevent that. I'm glad this is bringing that up. When I was watching you guys check off for IVs, I noticed when you put in your catheter, when you put in your cannula and you have, you know, pink, the little pink hub, if you're putting in a 20 or you have the little green hub, y'all do not be afraid. I don't want y'all touching the portion where the male part screws in, the little circle cannula part on the inside, but do not be afraid to touch the outside of that cannula and secure it. I don't want it flopping all around. I don't want it just hanging out right here. You need to take your hand and you need to secure that. When you're screwing in your lure lock, you can secure it here as long as you're not touching the inside portion. And you can still screw like this without touching anything. Y'all understand that? We're not just gonna leave it flopping around. If you want to do your little chevron, the little skinny piece of tape to anchor it down, you can do it directly on that pink piece, or you can do it on top of your tegaderm. You just need to make sure not to cover up that, you know, that site that we're monitoring, not to cover up that insertion site. But don't be afraid to secure the crap out of that IV, because that's what's going to stop your IV from infiltrating. If you tape it like a sissy, then now if you got tape all up here on their arm that's not holding anything in place and it's just there because you felt like putting it there, you know, that's not necessary. But if you are securing that IV and you have a piece of tape chevron here and you have a piece here and you have another piece here, and they are all serving the purpose to anchor down that IV, then that's going to decrease the risk for infiltration, because that IV is going to be maintained where it's supposed to be. You always want to monitor the IV rate for decrease or stoppage. If your pump is continuously beeping and you really can't find a reason why it's beeping, you don't see any occlusions anywhere, your IV is probably going bad, because it is beginning to get sluggish. It's beginning to not be able to go into that vein, and it's starting to infiltrate. So always be mindful of that. We're going to try not to put our IVs in an area where there's a lot of flexion. ER nurses always want to go right here because it's the easiest and it's the quickest, and you know, it's just your go-to. It's easy peasy. But the issue with that, when they're admitted to the floor and they're trying to sleep and they're trying to do anything, an IV that's here versus an IV that's here is a whole lot more likely to infiltrate because it's being manipulated so much. It's being moved around all the time, okay? We want to make sure that the vein has good blood return. Remember, I told y'all if you make a mess when you start your IV and there's blood coming out of that catheter, you probably got you a good little IV. You always want to pull back on your extension tubing. Ensure there's a little bit of blood in that line before you flush. And you want to monitor it hourly, 2 hours max. You're going to look at your IV site every 1 to 2 hours. All right, we know what infiltration is. The skin is going to be firm and tight, cool to touch, discomfort, and your IV fluids are not going to go in, okay? Extravasation is severe infiltration, and the solution that's going in is a vesicant. All of these words were in your vocabulary that we previously went through. That IV catheter is dislodged, and not only is it dislodged, the medication that's seeping into the surrounding tissues is harmful to those tissues. It results in necrosis, edema, skin sloughing, and pain. We want to always stop the infusion. We want to try to aspirate that fluid if we can. If we can pull it back from the catheter tubing and get some of it out, we can. Some medications have antidotes, and that's something we would have to notify the pharmacist and the physician to determine. And we always want to document that event. We can prevent this if we have the knowledge of what solutions are vesicants. We're going to monitor them a lot more closely, right? We're going to let our patient know, you let me know if this burns, you let me know if any discomfort is found before we go in there and check on them 2 hours later and their hand's black, right? Phlebitis is inflammation of the vein. It can be caused from mechanical trauma or a local infection. It can cause the development of a blood clot or thrombophlebitis. Redness, they'll have a red streak radiating up the vein from the site. So remember, phlebitis, inflammation of the vein, pain, edema, and warmth. And the vein may feel like a cord. So remember I told y'all, I don't know if I told y'all or not, when my husband was hospitalized last year, and he kept saying, my IV hurts, my IV hurts. And I'm like, oh my God, John, shut up. You're being such a tit. You're being ridiculous. And he kept telling him, and it was flushing fine, and it was fine. Everything looked fine. It was flushing, his meds were going in, no issues. He ended up having phlebitis, but it didn't appear like he didn't really have any of those initial redness or edema. It was just painful. An IV should be annoying, but it shouldn't necessarily be painful. You see what I'm saying? So we thought we kind of really did disregard his concerns because we thought he was being a man. And he did, in fact, after he finally was like, you have got to take this IV out and put it somewhere else. I've had an IV before and this hurts. So anyway, they took it out. And then after it was removed, he had the redness and edema, and he couldn't bend his arm beyond this for about a week because of the that vein feeling like a cord. It hardened and caused him a lot of aggravation, and he ended up complaining about that more than he did about anything else for his hospitalization. So in your assessment skills, knowing the difference, asking those extra questions. Has it hurt since I put it in, or did it just start hurting? Yeah, and you have had an IV before and it didn't feel anything like this. All of those things, because you may not get all of these signs at the exact same time, okay? Let's see. It can be caused because of the cannula being larger than the vein, the venipuncture over an area of flexion, and that's what happened with him. So when you think about this, they had it right here in the bend of his arm, and that cannula really aggravated his vein from the repeated bending there. That's it there. Change the IV site every 48 to 72 hours, or according to the facility policy. I've already told you guys this. For phlebitis, we want to apply a warm compress, monitor hourly, and document. Usually caused by traumatic insertion or inadequate stabilization. The infusion rate could be too rapid, causing inflammation to the inside of the vein. It could be too acidic or alkalitic, and the medications may be given into too small of a vein. It can be caused by bacterial infections, like failure to scrub the hub with alcohol. That blood clot that forms could obstruct the vessel. That is much more dangerous. If a thrombus occurs, do not irrigate the IV catheter. Remove the IV and inform the physician. That's your job if you are suspecting a thrombus. An air embolism is a bolus of air that enters the vein through an inadequately primed IV line. We prevent this by priming our lines. Don't forget to prime your extension tubing. Don't forget to prime your lines. Air embolism, a true air embolism, a teensy bubble is not going to cause an air embolism. But if we can avoid all the bubbles in the line, then why would we even risk that, right? And also it's going to decrease your patient's stress. But a true air embolism will result in respiratory distress, cyanosis, hypotension, and bradycardia. If that happens, you need to turn your patient to their left side and put them in Trendelenburg position. We're going to get an order for oxygen, get their vital signs, and have the code cart nearby. And we know how to prevent this. We want to secure all the connections. We're not going to let our IV fluid bags run out. We're going to remove all the air from the lines. Yes, ma'am, Kat.
What actually happens? Like when there's an air bubble, like when it goes through the heart or whatever, what is harmful?
Okay, so the reason that it's harmful, okay, so think about a blood clot, and kind of think about it in such a way. It's an empty space, and so that air bolus, think about it being, instead of a clot of thick stuff, it's a clot, it's an empty bolus. So it's essentially nothing going through. Does that make sense? It's kind of hard to explain. So in the same way that a clot would block that flow to the brain, to the heart, that flow is being blocked, but it's being blocked by air. It's very difficult to explain, but that's the best way that I can kind of make you get a picture of it. So, when the body is not getting what it needs, that blood flow that it needs, it will result in that distress. Does that kind of help a little bit? Now, that teensy weensy air bubble, and that's where these myths come in. I would have to look up for you guys the amount of air that it takes to cause an air embolus. It's not a teeny air bubble. It's a significant amount of air to cause that. But again, you don't want to ever walk that line of how much is too much. Whenever you're kids always want to say, well, I can't do this, but can I do this? Can I do this? If you can get rid of all the air in the line, get rid of all the air in the line. I mean, there's no reason to even walk that, how much air is too much air. But I will look it up for y'all just kind of as a common fact so that you can help your patients to know that that little air bubble is not going to kill you. That teensy bit of air looks much larger in that. So think about when we're flicking the bubbles out of our, when we're given IV push medications and we're flicking that little bubble out of the syringe. So think about how small of a volume that is anyway. What are we given? 1 milliliter? And then that bubble is maybe covering 100th of that little tiny milliliter. So 100th of a milliliter is not, that's minute. That's nothing. But again, it can cause your patients a lot threatening. But I'll find out that. I need to write that down to know how much air is harmful. And then a catheter embolism causes an obstruction in the vein that results from breakage of the catheter tip during IV placement or during IV removal. So when you're taking that catheter out, the IV catheter, and you're saying tip intact, you're essentially saying there's no extra little pieces of plastic floating around in my patient's vein, because that catheter embolism, in the same way that air will block their blood flow, that catheter will block their blood flow. And the same way, if that clot breaks off, it will block their blood flow. Being careful during insertion and taking your IVs out, that's how you prevent that. Low blood pressure, pain, tachycardia, cyanosis, and a decreased level of consciousness could all, if there is a catheter embolism, that is what we would see. We want to place a tourniquet proximal to the IV site. If when we take that IV out, we notice that catheter tip is not intact, placing that tourniquet stops it from traveling throughout their body, right, and going to their brain or their heart. Notify the physician, have that code card there. I've never had any of that stuff take place. The most thing that you will see when starting an IV on a patient is that vasovagal response. Sometimes when people are, y'all know about a vasovagal response, when they clench down because they're nervous, and they stimulate that vagal nerve, that can cause their veins to collapse, and they'll get white, they'll pass out, they'll kind of lose a little bit, not lose consciousness, but they'll vagal down, their heart rate will drop, they'll be diaphoretic and pale, they'll be super anxious, their heart rate will drop. So what you need to do in that case, you need to get a cool rag, you need to have them cough if they are still alert. Coughing sometimes helps them to not bear down, because you can't bear down and cough at the same time. So coughing, putting them in Trendelenburg, cool rag, all of those things will help that. But usually it passes on its own. Septicemia, we talked about. Y'all know that. It's life-threatening. That's why we need to take care to use aseptic technique. If they are septic, we are going to give them antibiotics. We're going to monitor for signs of infection. We're going to monitor their white count. And we're often going to obtain blood or IV site cultures. And all of the things that we previously talked about in the asepsis section is how we're going to prevent that. Circulatory overload is an increased volume in the intravascular spaces. It's going to present much like heart failure, increased blood pressure, jugular vein distension, respiratory distress, and a change in their INO. If we're going to put them in circulatory overload, if their IV flow rate is too rapid, or if they have cardiac or kidney problems and they cannot sustain the amount of intake that we are giving them. We want to sit them up, and they'll be able to facilitate their breathing better if they are sitting up. Oxygen, notify the physician, and then oftentimes we'll have to give cardiac meds, sometimes Lasix, sometimes other cardiac medications to get them back to baseline. We are going to prevent this by just making sure that if our fluids are if our fluids are ordered to infuse at 75 milliliters an hour and we accidentally put them on 175 an hour, that can cause circulatory overload. So checking your pumps, making sure that all of your calculations are correctly, and doing good physical assessments. We don't want them to be short of breath, sat in 80 before we realize that there is something going on. We want to notice when they have that slightly labored breathing when they get up to go to the bathroom, or they have mild edema to their ankles. We don't want to wait until they're in full circulatory overload before we recognize this. In all of our IV therapy complications, prevention is the key. We always want to instruct our patient on how to properly position the extremity. I used to tell my patients, you want to baby that IV. You can move your arm. You don't have to be a robot, but you still want to baby it. You don't want to pull at it. You don't want to, pick at your tape or mess with it much. We want to instruct them on proper care. We want to let them know if it feels different, if it feels warm or painful or there's redness, let me know. Don't wait for me to, come look at that. We want to teach them precautions regarding bathing and showering with an IV. We don't want their family disconnecting it to put their gown on because they haven't learned aseptic technique and they might lay that tubing on the bed, right? We always want the IV fluid bag to be above the IV site. We want them to call us if their pump beeps. We don't want them to just silence it because that beeping pump may be our first indication of infiltration and they're steady silencing it, then we are not able to do what we need to do. We want to instruct them to not adjust the IV fluid rates. We do not want them to really mess with their pump at all because that's our responsibility. That's what we're monitoring. And then, of course, we want them to keep their dressings intact. Questions about